Hi, Jason. This is a grossing tutorial video on how to cut in or gross in a radical nephrectomy for tumor. So we have a kidney here, or a radical nephrectomy for cancer, and it's surrounded by an abundant amount of attached fat and some Gerota's fascia. So basically you have fat surrounding the kidney, both anteriorly and posteriorly, and then in between the fat and the actual kidney, you have some planes of fascia, which are called Gerota's fascia, and that's what this is right here. This is perirenal fat. So the first thing that we do with these kidneys for cancer, we're not going to weigh them, for one thing. I know that some places actually weigh these kidneys with the fat on it, which makes no sense at all. Whether it's for kidney for cancer or for a disease process, if it's for kidney cancer, there's no reason to weigh these. If it's for a disease process, it's good to cut off all the fat and then weigh the kidney itself by itself. So anyways, the first thing we're going to do is we're going to kind of go over the anatomy of the kidney, talk about some of the sections we're going to take, show you how to open the kidney to let it fix for a while before you actually process it. But anyways, once again, we've got a kidney with perirenal fat, Gerota's fascia right here. It's kind of disrupted, as you can see. And the first thing we're going to try to do is we're going to try to locate the hilum, or the vessels at the hilum, and the ureter at the hilum that kind of entered the kidney before the surgeon took out the kidney itself. I noticed on this kidney it's disrupted right here, and actually there's an area of separation of the kidney capsule from the kidney cortex, and so you got the separation here. So it looks like what they probably did is they probably went in and tried to do a partial nephrectomy, and it didn't work out, and so they went ahead and did an open surgical procedure, and took out the entire kidney with the perirenal fat. So once again, here's some kidney cortex that's exposed. Here's the capsule. Here's some separation. There's a lot of areas of cautery in this area here, which also makes me think that they tried to do a partial nephrectomy, or thinking of doing that. And they only do that on patients that usually need both kidneys. Maybe they have, stage 2 or stage 3 or stage 4 kidney disease, and they're trying to preserve as much kidney parenchyma as possible. So what I notice right now, there are some staples here, and some cautery, and some more staples here. So it looks like we're in the area of the hilum. And when we talk about going from anterior to posterior, as far as order goes, it's the vein, artery, and the ureter. So we say VAU, or an acronym VAU. So looks like this is the hilum here. Looks like there's maybe some vessel here coming up like this. It certainly looks like that. There's some vessel there, and this may actually be a gonadal vessel, or an accessory vessel, not necessarily the primary renal artery vein and the ureter. And it looks like here we got the ureter. So that's the first thing I like to find, is the ureter on these cases. And also kind of take a brief glance and make sure you don't see any adrenal gland or any other anatomical structures that are or are not supposed to be there. But here's the ureter. Here's actually the ureteral margin. I'll sample here in a minute. But first thing I want to do is get this thing open, and so it can fix in the formaldehyde for a while, the fixative. So what I like to do to kind of open up and expose everything, hopefully the tumor too, is I take the actual ureter and I'll put a little slice in the side of it like that, so I can get this probe within, sorry, wrong end. You probe within this ureter, and it looks like I did, so that's good. So now I'm just going to kind of gently push it into the renal pelvis, and I'm going to push it through the cortex of the kidney. Now, some people like to ink these kidneys entirely before they do any of this opening business, but I seriously like to put the ink on after the fact, after I've already taken all my sections. In this case, I'm going to go and put a little bit of ink on it because it is disrupted in this area of the kidney cortex. So let's throw a little bit of ink on this in the area of the soft tissue margin, we call it, or the margin. So it looks like the tumor is actually probably right here. It's very kind of distended or nodular or enlarged in this area right here, adjacent to the kidney parenchyma. So I'm going to go and put some ink here at least. But like I said, I typically don't ink these specimens until after I've already opened them and kind of evaluate where the tumor is in relationship to different structures. So I put the ink on there. We'll go ahead and put some mordant or some vinegar on it, and that is going to make the or help the ink stick to the specimen. I'm going to dry it off a little bit like that. And now I'm going to open this up, and like I said, I'm going to let it fix for a little bit, so we'll probably open this up and we'll come back to it. Anyways, I like to take the probe and kind of push it, hold it down like that so it's a little bit more sturdy. And then I'll take this blade and I'm going to cut along the probe about a 45-degree angle and try to really get a good slice, like I said, exposing both the renal pelvis and the kidney parenchyma along with the tumor. And I also like to rinse between doing these cuts. So if I do cut into tumor, it's not going to be going everywhere. And here I am opening it up. Just like that. And so what we have here is this is all a bunch of tumor right here. And then this is the renal pelvis that I just opened. I've exposed the entire renal pelvis because the reason I like to do this is because you cannot, I mean, it's not very often or very common, but you can have a renal pelvic mass, like a transitional cell carcinoma, and that could be a primary, right? And then you can also have a parenchymal tumors, which is what I have here, a yellow, dark red renal cell carcinoma here at one pole of the specimen, which actually looks like it's pushing into the renal hilar sinus fat. So I'm glad I inked everything on that side. But once again, we just put the probe into the ureter, push it through the cortex, cut along that probe the best you can. It's better if you can get one nice slice. And then we're going to expose the renal pelvis and also the renal tumor and put it back in the container. And then we'll go back to it here in a little bit. Alright, this is Jason again. So I'm coming back to the specimen that we let fix for a little while. I kind of closed the area where I had bivalved it or cut it in half almost. So now the next thing we really need to do, actually the first thing you need to do as far as what sections to take, is we're going to be looking for the hilar, vascular, and ureteral margins. And those are sections of the artery, vein, and ureter at the hilum. And we're going to take those very end sections and put that into the first cassette that we have. So this is where the area of some staple lines we're at. So this is where our vascular margins are going to be. And we already know where our ureter is at because we actually used that to open up the kidney or bivalve it. So here's the ureter here. So we're going to take a section of that and put that down with the ureteral margin down first. We're going to come over here and cut across these staple lines. Now, some people, there's two different thought processes on this. You can either cut right underneath the staple line or cut extra tissue subjacent to the staple line so you can then take your vascular margins or ureteral margins. I like to just take these staples right off from where I found them and then take the next section underneath that. So right here, there were some staples, but underneath it, there's just some fat. So we're going to continue our search for the artery and vein. And here's some staples right here. I'm going to cut immediately subjacent to it and see what I find. So here it looks like we've got the artery right here. So the renal artery. We're going to take that and put that cut surface down. Okay, so far we got the ureteral margin, we got the arterial margin, and now here's another staple line. This is going to be our vein, the last of our vascular margins. This is the vein. So we're going to take this section here and put this face down. And so we got our two vascular margins, we got the ureteral margin. So we're halfway there. Now earlier, I think I was calling this a gonadal vessel, and that was incorrect. This is the actual renal artery. This is kind of a disrupted specimen, so sometimes the anatomy can be kind of backwards or kind of different. So we've got the vein, the artery, and the ureter in that order, right? VAU from anterior to posterior. And then what I like to do, so after taking those margins, I like to go ahead and open up those vessels to make sure there's nothing in them before I even touch any tumor, because I don't want to accidentally put any tumor in any of these vessels, the artery, the vein, or the ureter. So there's nothing going on there. And then here's the actual the ureter here, so I'm going to open up this bad boy and make sure there's no tumor in here. I'll just cut it all the way to almost the uretero-pelvic junction, and just kind of take a look and make sure there's no tumor in there, and there's not. So we can comfortably say that there's no tumor in the artery, vein, or ureter. Okay, so that's cool. Now we're going to go back to the area of tumor and try to get a good guesstimate on, not guesstimate, but actually try to get a good size on this tumor. It's also helpful to actually look in the history, the imaging for this patient. Often the dimensions in the imaging are the same or just about equivalent to the dimensions you get on the gross that I have found anyways. So let's go ahead and here and cut through here. Now it looks like, so we have some tumor here. Now we know that this is not going to be, well, one thing we know, it's at one pole. So which pole is it at? It's at the superior pole, because we were over here at the hilum a second ago, and the ureter goes in this direction. So we know that the cancer, or the tumor's in the superior pole, so that's important. It's parenchymal, okay? It's not in the renal pelvis. It's not originating from the fat. It's originating from the parenchyma. So it's a superior pole parenchymal mass, and then we need to get the dimensions of it and talk about its relationship to the inked margin, the renal pelvis, and other structures. So anyways, right here we've got just a part of the tumor here. This dimension here, this dimension is not going to be important, but from here going this direction, it is. We want to get that thickness there. We'll have to add it to the cumulative size of the tumor. So looks like we have, it's 1.5, so we're going to add that to the dimensions going this way. So let's go ahead and get a blade here. I'm going to rinse between slices, so you're going to hear the water running. We kind of have to do that. So let's cut right down the middle of it the best we can to try to get an accurate size. And like I said, I'm sectioning through it, but I'm also rinsing between slices. So I'm going to turn this midsection slice this way so I can get the dimension, that one direction. Okay, so we've got a 5.5, okay, plus the 1.5, so 6.5, that's 7 cm, okay? And then this way, or this direction, from the cortex towards the hilum, we've got 7.5. Well, that doesn't happen often. And you're always, always feel free to look at these staging criteria so you know what are some pretty close and critical sizes for tumors and whatnot. So let's just go and take a look at this too, just to make sure. This is 6.0 cm as well. So we know it's 7.5 by, now look at this dimension here though, see? This is 8.7. So we actually have 8.7 by 7.5. Now we need to do the dimension going from this direction to this direction here. So it looks like the tumor, so what we're going to do now is we're going to go down the middle of this piece right here, and we're going to get this dimension here and add it to the other dimension over there. Wow, so over here we've got a 3.8, and sometimes you have to write these things down if you think you're going to forget these things. So we've got 8.7 6 by, let's make sure I had that right. I'm sorry, we got 8.4 by 7.5, and our last dimension here, we're going to get from here going this direction, from superior to inferior, going down the middle of the tumor. You got to make sure you stay on the same plane when you measure these tumors. So that's 4.0, and then let's cut down here. I'm going to rinse between slices once again because you get some artifact otherwise. Okay. So once again, we got 4.0 plus 3, so 7.0. So we've got a superior pole parenchymal tumor measuring 8.4 by 7.5 by 7.0 cm. It distends the kidney capsule. As you can see here, it distends it, or it kind of stretches it or thins it out. And it looks like this tumor abuts the soft tissue margin. Where all this blue ink is, looks like the tumor's abutting it here. And there is some capsular thickening and fibrosis here. Now, the fibrosis part of it could be just indicative of a sarcomatoid component. So we'll make sure we sample some of this. But our sections are really going to be concentrated on the tumor in relationship to the soft tissue margin, right? And other structures. Let's come back to that part here in a second. Hey, it's Jason going back to the case. I'm going to be taking some sections of the tumor and relationship to things. So I'm going to be taking the sections of the tumor to the closest soft tissue margin in the area of distended kidney capsule. I'm going to take a section of a tumor to normal kidney parenchyma, and I'm going to take a section or sections of the tumor in relationship to the renal hilar, the renal pelvis, or the renal calyces or calyx, whatever's closest to tumor, and put those in the blocks over here. So we know by when I did the sectioning that the tumor in closest soft tissue margin is in these areas over here, and there is some areas of fibrosis. Like I said, that could be a sarcomatoid component, or it could actually be some thickening of the kidney capsule, which could be worrisome, especially if there's extension through the kidney capsule. So we'll make sure we sample those areas. And what I like to do is once again use a really sharp blade and rinse if I have to between sections. So here's like I said, some sections where it's really close to the soft tissue margin, and there's some areas of fibrosis, so I'm going to cut through there. And it's not unheard of for me to sometimes take these sections and rinse them under water so there's no artifact, but I think I'm doing pretty good so far. So we'll put a section there. We'll take a section from right here. It looks a little thickened, and the kidney capsule is kind of firm in this area, so we're going to sample that. Okay. So just kind of depending what you see grossly will kind of dictate what sections you take and how much you take. I usually only take about 2 sections of the tumor to distended kidney capsule, but in this case I'm going to go ahead and do a little bit more, since it's kind of areas of fibrosis. So I've got 3 sections up here of the kidney tumor in relationship to the soft tissue margin in the area of distended kidney capsule. I'm going to take a section of now of the tumor to normal kidney parenchyma, which is, here's a section right here. That'll work. There's that. And then, you know, looking at the area of renal pelvis or pelvic urothelium, I don't really see anything that looks worrisome here. However, over here, this tumor is right next to an area of pelvic urothelium or even a calyx or calyce. It looks like it's probably going to be the closest area of a tumor to the renal pelvis or the pelvic urothelium. So I'm going to make sure I take some sections of that right there. So there, and then the section right here. And I might see if we can find any other areas that look like might be good representation, like in this area here. And sometimes when you do this, when you're sectioning through the hilum, if the tumor is pushed out in that area, you might even end up seeing some vein or involvement. So right here is some more renal pelvis or pelvic urothelium. So I'm going to go and take a section of that, make sure there's no tumor involvement, because there's some areas of fibrosis here as well. All right. So now that I've done that, I've taken basically all my sections. I'm going to come back with a bigger blade and kind of cut through more of the specimen, make sure there's not a second tumor, and make sure I haven't missed any areas of tumor extension through the kidney capsule. Some people open up, cut the kidney or open it up like a book. Now right here, I see a little area of possible additional tumor, which is completely, well, the question is it completely separate from the main tumor? And it looks like it is. It's completely separate. So I'm going to take a little piece of this and sample it. A piece here, the same sample. I'll mention that in my dictation. And it looks like it's about 5 millimeters or 0.5 cm. Anyway, let's continue our cuts through here and make sure there's no additional tumor that I'm missing. And it's not unheard of to find additional tumor. Like I just found another area right here where it looks like there's some possible tumor. So I'm going to sample that as well. That's about 3 millimeters or 0.3 cm. I'll sample that. And I also like to go back to these cases, especially if I find additional possible tumor, and see if I was correct or if it's just something else, like a benign process. It looks like tumor. So as I'm cutting through here, I'm going to rinse my blade, because if I hit tumor, I don't want to spread it throughout the specimen. And there's a couple more things I'm going to sample. I'm going to sample some normal kidney parenchyma, and I'm going to sample some renal hilar sinus fat adjacent to the tumor, okay, as well. And then I'll be about done. And once again, these are the areas that I was sectioning and sampling the actual tumor itself and to the closest soft tissue margin, and just kind of cut through here and see if I see any additional areas that look worrisome. I want to be thorough, right? You want to be thorough on these cases and make sure you don't miss anything. So that's what I'm doing right now. I'm not seeing anything. All right. So I've got my first cassette with the vascular margins and the ureteral margins on FOSS. I've got 3 cassettes of tumor to closest soft tissue margin in the area of distended kidney capsule. I've got kidney parenchyma to normal, tumor to normal kidney parenchyma. And then I've got 2 cassettes of tumor to closest pelvic urothelium or urothelial mucosa. And I've got this bisected area of possible tumor at the inferior pole of the specimen away from tumor, an additional section of possible additional parenchymal tumor at the inferior pole away from, at the opposite end of the kidney away from tumor as well. So now I want to get some renal hilar sinus fat and some normal kidney parenchyma, and then I'll be done. So when I sample this, I want to make sure it's clean, right? I don't want to have tumor. So this is some tumor here, and I'm going to try to find, so here's tumor right here, and here is some renal hilar sinus fat. So what I'm going to do is I'm going to gently rinse this off, some water. I'm going to take some brand new forceps that are clean. Now I know absolutely are clean, right? And it'd be nice to have teeth on them, because I can kind of really take some good samples here. So now I'm going to take 3 small pieces of renal hilar sinus fat. Okay, that's close to the tumor, but not directly involving the tumor. I suppose you could take sections of tumor in relationship to renal hilar sinus fat directly, but I feel a bit safer doing this because I'm not cutting through any tumor at all right now, right? So I'm going to put those 3 sections through. And then last but not least, I'm going to take some normal kidney parenchyma. I guess I can take it from here, the cortex, right? So I just want to make sure I get some cortex here. And I'll put that sample through at the end. Okay, so one more thing that I need to do. And I suppose you could do this at the beginning, but I usually do it at the end as I go back to the renal hilum here. And I kind of palpate and make sure I don't feel or see any lymph nodes. It's not very often that I find any lymph nodes at the hilum of the kidney. But sometimes when you look up the tumor size in imaging, it'll say, oh, there's some enlarged lymph nodes at the hilum. So there'll be some. So I'm not feeling any, I'm not seeing any. And so we're done with this case. Once again, first cassette, vascular margins, ureteral margin. Next 3 cassettes, tumor to kidney, distended kidney capsule. Includes areas of fibrosis and closest soft tissue margin. The next cassette is tumor to normal kidney parenchyma. The next 2 cassettes are the tumor to renal hilar sinus fat, or calyces or calyx, whatever's closest to tumor. We've got the bisected area of possible additional tumor at the inferior pole. We got next cassette 3 pieces of renal hilar sinus fat closest to tumor or adjacent to tumor, and then another area possible kidney tumor separate from the main tumor at the opposite pole. And last cassette is kidney parenchyma away from tumor. Thanks for watching.